Well, welcome everyone to ADA's Obesity Association Standards of Care in Overweight and Obesity session. I'm Nohal Said. I'm Senior Vice President of Healthcare Improvement. That's my day job. And I have another job, which is interim for Chief Scientific and Medical Officer for another month. I have no disclosures. And I wanted to start us off talking about the obesity standards of care and how this is created. And it takes a village to create a standard of care. And we are very privileged that ADA Standards of Care is co-created with various amazing organizations who've been in the field for a very long time, each of which are represented by voting seats in what we call the Professional Practice Committee. We go through a process of extensive literature search, and I think Kim and Lou here are an attestation to what happens. We look at a lot of data, and then based on that, we develop recommendations based on all of this evidence, and these are graded based on the strength of evidence, and you'll find that each recommendation will have language that says things like you should, or you could consider. So it will usually relate to the level of evidence that is supporting whatever recommendation that we do. Our Professional Practice Committee is a committee that is formed on an interprofessional approach. We need to have representation of the workforce, as well as patients that are impacted by obesity. We have currently, I think we have 15 voting members, and we have an extensive number of experts. So if it's something that is very, very small in the standards, but it's also very important, we invite experts to join us to inform our voting members to give you the best available evidence and recommendations. We then go through an extensive peer review process, an ADA scientific review process. All our standards, including the obesity standards of care, are funded by ADA's general revenue. And what that means is this is not industry sponsored, there's no financial support from any outside organization. So it comes from things like your membership to ADA and things along these lines. It is my honor and pleasure to introduce Dr. Kim Gajoni, who will be talking to us about two things today. One, it will be an introduction and the need for comprehensive obesity care. And she will also be covering weight stigma and bias because Dr. Fatima Cody Standard was not available to be with us today.
Well, thank you, Nuha, for the introduction, and it's really exciting to be with you all here today. And really, it's been my honor and privilege to work on this project, which is so near and dear to my heart, and really thinking about how do we advance the care for people living with obesity. I have no disclosures. So if we take a step back, I think a lot of us are familiar with the increasing prevalence of obesity over the last few decades. The most recent estimates place about 40% of U.S. adults would have obesity. I think the other thing to keep in mind is the most severe form of obesity, class 4 obesity, is now almost 10% of the population. And it's not just adults that are impacted. Recent data also estimates that nearly 20% of U.S. children have obesity. So, it seems like we've been hearing obesity is rising in prevalence and this concept that obesity is a disease. This has not always been the case. I think it's interesting to me now when I talk to young physicians, they don't question that obesity is a disease and should be treated as such. But it really was back in 1999 when the World Health Organization actually first made a statement that obesity is a complex, multifactorial disease that is incompletely understood and requires long-term strategies for its effective prevention and management. And it wasn't really until 2013, so 14 years later, that we saw the American Medical Association also make a statement that obesity is a disease state. When something isn't categorized or thought of as a disease, thinking about how do we treat it and why should we treat it is a real struggle. And it allows for then payers, clinicians, patients saying this is not something that I should go into the healthcare system for treatment. After the AMA made that statement, I think those of us who have been in the obesity medicine space for a while were, one, really excited, but then also to see, would this change the opinion of our colleagues? There were some focus groups that were done after the resolution was passed where there were still a lot of doubts. People would think that it's a risk factor for disease, but not a disease itself. They were worried that patients would lose accountability for their behavior if we said that this was a disease, and that they were worried that there could be a negative effect on patient and physician interactions, that people don't want this as a diagnosis. How will I continue to talk with my patients after that? I think since this time, we've learned a lot of things, and also taking from other chronic disease states like type 2 diabetes, like hypertension. There's a lot of similar parallels that we can think about in obesity as a chronic disease. And thinking about attitudes, this is of U.S. physicians about obesity, and this was after that AMA statement came out. If you ask them, is obesity a disease? We have a majority of physicians from different specialties now saying, yes, it is a disease. But there's still a good chunk of folks saying that obesity is a lack of self-control. So there was a little bit of a dissonance between, yeah, we know we're supposed to say it's a disease, but then are we actually truly believing that it's a disease? And there was a lot of communication barriers identified in this study, that people didn't want to bring up obesity still because they were, again, afraid of offending the patient, that they never got any training on how to discuss obesity or how to treat obesity. And I think back to my own medical training, I had basically a lecture that was really focused on epidemiology and some basics of pathophysiology, but I really never learned how to talk to patients and, more importantly, how to treat it. A lack of resources of where you can refer people, and that really this pessimism that they thought that they would have little success in helping their patients with weight reduction. And this is some data from NHANES of adults. And if we think about, who is eligible for care and are they getting care? And so if we take all adults with obesity in NHANES, about 93% of them perceive that they are overweight. So it's not that patients don't know that this is an issue, so that's not where we have the gap. And 92% of them want to lose weight. So again, it's not a lack of interest in potential treatment that is the gap. But here's when we start to have a drop off. The trying to lose weight drops down to 60%, and sought professional help of any kind, 10%, and then sought a doctor's help was only about 4% of patients. So there's really missed opportunities here. People living with obesity are interested in care, and we need to think about how to actually get that care that they're interested in. So obesity treatment can really be thought of as a pyramid, that we have a multi-component lifestyle intervention at the bottom, which you're typically going to get somewhere between 2 and 8% weight reduction. We have multiple obesity medications, which vary between 5 and 20%. We also have endoscopic procedures that are available, again, somewhere between 10 and 20%. And then at the top, we have metabolic bariatric surgery, where you might get between 25 and 40% weight loss, depending on the procedure selected. And so as we go up this pyramid, we have increasing cardiometabolic health benefits, which is great. We have all of these tools. Unfortunately, the clinical use as we go up the pyramid gets lower and lower and lower. And so, for example, for metabolic surgery, about 1% of eligible patients end up pursuing that as a treatment option, despite all the evidence regarding its efficacy. And so in thinking about, what is happening in primary care? So my background is in internal medicine before I started practicing obesity medicine. And so primary care settings are something very sort of near and dear to my heart. And if we look at this, are there any changes over time? It's really a very low uptake of obesity treatment services in primary care. Nutrition, it's about 3% of patients who would be eligible. Obesity medications, again, somewhere between 2 and 3%, and then bariatric surgery, even lower. And just any obesity treatment, again, was only 5% in 2017, and in 2019, only 7%, so a minimum number of individuals. And that when we talk to our colleagues in primary care, how do I inform my treatment decisions? Less than 10% of primary care practitioners say that they use guidelines to inform their treatment recommendations. So again, we have a little bit of a dissonance there. So sometimes we have the impression that people, again, don't want these services. And this is looking at adjusted probabilities of being referred to weight loss services and then actually attending a visit. And the different colored lines here are by different patient BMI, with green being patients with class 3 obesity of a BMI of 40 or greater. And as we see on the left-hand side, this is receiving a referral. So many more patients with that BMI of 40 are receiving a referral to some type of weight management service. And it's oftentimes the younger individuals. This is age along the x-axis here. And our older individuals, though, are really not receiving referrals as much. But then when we look on the right-hand side, this is if you got a referral, did you actually attend? There really isn't a difference between these groups, that if people are getting the referral, they're actually going. And so I think that really says, how can we begin talking more, and it's either delivering care or referring to those individuals who can deliver that care. So why does this gap potentially exist? And I think one of the big challenges is that while those of us in the obesity medicine field think about this all the time, because so many of us never receive training, how do we actually do this? What do we need to do? And so having a standards of care to set those expectations that are both evidence-based, patient-centric are critically important in thinking about how we can actually promote what we should be doing in clinical practice more broadly. And we're thinking about this holistically, from prevention, screening, diagnosis, to obviously treatment. As Nuha mentioned, the standards of care is being developed by the Professional Practice Committee, and really bringing together a whole host of experts, not just obesity medicine physicians like myself, but dietitians and psychologists, to have everyone really represented. In addition, those key collaborators from other obesity organizations are also really heavily involved in really collaborating to make this standard of care together. And so really our approach with this and the framing overall is taking a complication-centric risk reduction and disease burden reduction approach. So we're going to be incorporating, preventing, and managing obesity-related diseases and complications. So this isn't solely you need to lose this much weight. Obesity, as it affects every system in the body, we need to think more comprehensively than that. We're also going to be focusing on tailoring of treatment recommendations for people with obesity. So it's not always a one-size-fits-all approach with this. We really need to think about individualizing to certain specific needs. And then finally, helping healthcare professionals identify individuals who may best benefit from treatment. And so really there are 4 aims for the standards of care for obesity. First, we are aiming to create personalized, equitable obesity care. We want to improve long-term health outcomes for individuals with obesity, as well as to enhance treatment accessibility, and again, try to bridge those clinical gaps that I demonstrated previously. I'm going to also be covering, you get me twice, to talk about the weight bias and stigma. And so earlier this year, the introduction chapter as well as the weight bias and stigma chapter were released and are now publicly available. These are just the first 2 of a series of chapters that we'll be developing, but wanted to share with you really what does the weight bias and stigma chapter contain. I think before I get into the meat of it, this was a very intentional choice of selecting weight bias and stigma as our first chapter, as weight bias and stigma really impacts the lived experience and particularly the healthcare experience for people living with obesity. And so if we don't tackle this first, if we don't have a welcoming environment for people to receive care, why are they going to want to receive care even if we have all of this evidence base around it? So really, we need to sort of think about this first. So the recommendations are really centered around kind of three core principles. First is education and training, thinking about our clinical environment and practice, and then finally around communication and collaboration. Before I get into those, I wanted to pause and talk a little bit about weight bias and stigma and where it can occur. So a lot of us may think about weight bias and stigma occurring in sort of an interpersonal interaction or relationship, and that definitely can happen. And so this can be both explicit, these are attitudes and beliefs that we endorse if you ask us if we have them, or they can also be implicit or subconscious, things that we actually don't know, and there are ways to test and identify whether that is a bias that you have. We see when we survey healthcare professionals and just the general population more broadly, that people living with obesity, oftentimes people will endorse that they don't like them as much. They blame them for having their chronic disease. There's disrespectful verbal communications. Sometimes clinicians will vary the treatment for a condition that's not related to their obesity, but because that individual has obesity, and also denial of care of just not providing services to those individuals. We also have more institutional or structural ways that weight bias and stigma can come into play. And these can be discriminatory policies, non-inclusive culture, inadequate physical accommodations. So thinking about, again, that environment where you walk in, do you feel welcome to be there? And then finally, intrapersonal. So individuals living with obesity will have internalized stigma or self-stigma, that they actually hold that negative bias towards themselves. This is oftentimes a result of years of anticipated judgment, mistreatment, living in the culture that we do where we blame individuals for their weight. And then you take that and you internalize that yourself. This is associated with a lot of negative health outcomes, and so it's really important for us as healthcare professionals to be aware that this may exist and really sort of talking with our patients about that aspect. How common, I think a lot of times we don't like to admit as healthcare professionals that we may be biased against our patients. And this was a survey of residents, across the country in different specialties. These are specific, this is an explicit bias saying that they dislike people living with obesity. And we see that there are some differences by specialty, but overall, there was a preference, I guess you could say, for having these negative attitudes, that they were there. And again, it's more of a result of our cultural belief system around weight. So weight stigma does have consequences to the individual living with obesity. And this is work that Rebecca Poole did a few years ago, and really identifying all the ways where weight stigma may influence that individual. So weight stigma will increase stress, which then is associated with changes in eating and physical activity behaviors. So for example, individuals who experience weight stigma are more likely to engage in binge eating. There's also physiologic reactivity to that stress, which is not unsurprising. And so we see increased levels of cortisol, hemoglobin A1C, and blood pressure. There's also, as a result of weight stigma, differences in healthcare services. And so there's less trust. People will avoid following up. They avoid coming into clinic, a delay in preventive health screenings, and impairment in communication. All of this can then lead to weight gain of the individual, so we then have this cycle starting. And there's then further psychological distress, so there's increased rates of depression, anxiety, low self-esteem, and physiologic health distress. So again, issues with poor glycemic control, more advanced or other poorly controlled chronic disease. So this has real health impacts, which is why we think it's so important to have it as a primary focus. So what can we do? I've painted sort of a doom and gloom picture here. First is thinking about education and training. And so the first recommendation statement was that all clinicians and staff should be trained on weight bias and stigma. So luckily, there are some, and listed in this table here and available in the document, there actually are some stigma training resources that are already available. I think from a practical side of, previously directing a clinical program, like, okay, that's great. Well, how do I do that? Well, here are some resources for everyone to get started. And it's not just the clinicians, but in thinking about really the whole staff. When a patient comes into a clinic, that front desk person or the person they speak to on the phone, these biases can be communicated. And so having an awareness of everyone and having some strategies to mitigate that are a really key first step. And thinking about the clinical environment in practice, so we have 3 recommendations here. And really the idea is to make changes in how our clinics are set up so that everyone is welcomed and we're decreasing that risk of stigmatization. So first, we want to think about implementing protocols to minimize risk of stigma during provision of healthcare services. And so this is really, again, thinking about not just for sort of the physician in the room, but the entire staff. And so this can be thinking about what are your practices around weighing someone when they come into your clinic. The third recommendation here is to make accommodations for privacy during measurements. So locating the scale in a private area where, I think back to all the times that I've gone to the doctor's office and like the scale is in the middle of the hall for everybody to see. And then the staff will be like, woo, like you gained some weight. And so it's really thinking about how can we, I'm giving you an extreme example, obviously, but there are small things that we can do by having that happen in private and really talking with staff about how to talk about this. Some may also be aware that some patients don't want to know their weight or they're refusing their weight. And so these are conversations and opportunities, I think, for us as professionals to understand why that is and then to how to best tailor that to patients' needs. Also, once they get into the exam room, and this is where this middle recommendation is coming in, is making sure that we have clinical equipment and furniture available that accommodates everyone. And this should really start from the waiting room all the way through the checkout process. And so, chairs, examination tables, gowns, blood pressure cuffs. And it really should be something that is, in an ideal world, not, oh, I have to go get the X for you, but it's already in the room, so it's a normal part of the care process to accommodate everyone. In the document, we do have a checklist of kind of some minimum accommodations. There are other checklists out there that are available that have much more extensive, and thinking about sort of a bare minimum of what we would hope for all clinical practices to try to achieve. And so I would encourage you all to look at this and really do an assessment. Do I offer this in my practice right now, or are there ways that we can improve this? And then I'll end on the topics of communication and collaboration. So our first recommendation for this was to use person-centered, non-judgmental language that fosters collaboration between individuals and healthcare professionals. And so this comes in multiple ways, and we have a table here of examples of preferred language. And so this for me is not just in thinking about using the term of a person living with obesity, but for those clinicians out there who also bill and put in diagnosis codes. Now that patients can see their charts, they can see their diagnosis codes, it's really important for us to think about using E6601, morbid obesity due to excess calories. Well, is that even actually a true statement for this individual, where instead we can use something like class 3 obesity or other obesity, and to avoid using stigmatizing and pejorative terms in every aspect of how we document and communicate with patients. The final two recommendations regarding communication and collaboration. The first one is engaging people in shared decision-making, really to individualize their diagnostic and treatment approaches, and really to have that collaborative goal setting that is beyond weight reduction. While weight reduction may be a goal, at the same time, there may be other goals, and really understanding that person holistically is really key. And that a obesity treatment plan is not just a one-time discussion or a once-a-year discussion, that this is really a long-term collaboration, and so setting that expectation with someone is really important. This last one, I think, is sometimes new to folks, but I think is really important, and that is before you enter into this conversation about obesity treatment, is to first ask permission of the individual if you can even discuss their weight. Given that experience of stigma in healthcare settings, over the course of my career, I've had so many patients come in and tell me that they came in for a sore throat and were told that they should lose weight, that these things have nothing to do with one another, and it just makes them feel unwelcome and not seen and not valued as a person. And so asking that permission is really critically important. Sometimes a person is not interested. Sometimes a person is not at the time point in their life where that's something that's at the top of their agenda, and we really need to respect their autonomy in this decision-making process. I think it's hard, though, sometimes for us as clinicians. We're like, oh my gosh, but we have these treatment options, and what about the health risks? And really, it's learning to sort of decline and respect that autonomy and forcing a conversation. You can let people know that if they ever do want to talk about it, you're there, you leave that door open, but that forced discussion really doesn't do any service to the patient nor to your relationship that you're trying to build with them. And then finally, if individuals are interested and do want to accept a discussion, it's really helpful to understand and actually ask them how would they like to discuss it. People have different preferences around words. So in this space, we use the term obesity, which many people may be worried about actually using that term with their patients, and there are folks who don't want to hear that term. And so asking a person what is their preferred term of how can we have that conversation in a way that's respectful to you is really key, and again, forming that relationship, which is critical for long-term care. So I'll end today with a few action steps. The first one being to integrate comprehensive obesity education. And so ideally in medical schools, residencies, if you are an educator, thinking about how you can incorporate this. And if you're in a practice, making sure that all of your staff and other providers have, at minimum, education on weight bias and stigma. Enhancing that clinical environment, really key, and there can be small steps that we can take to really improve that welcoming experience. And finally, thinking about ways that we can promote effective communication and collaboration. So using person-first language, engaging in respectful dialogue and shared decision-making is really key in overcoming the weight bias and stigma that so many people living with obesity have experienced their entire lives. So I will end there, and I will pass it on to Lou.
Thanks a lot, Kim. Really appreciate it. And I really appreciate all of you for your interest in obesity. I think one of the most important messages of this session is that the ADA needs to recognize that obesity talks need bigger rooms because a lot of people want to see them, right? We're absolutely full here. I mean, when you think about the results of the SURMOUNT-1 prediabetes trial led by Dr. Anya Yastrobov, who I saw standing in the back before, 94% reduction in progression to diabetes from prediabetes with treatment over 3 years with a GLP-1 GIP dual agonist. 94% reduction. So does that mean we're going to have 94% fewer people going to lectures about diabetes because there'll be 94% fewer people with diabetes in the very near future? So I think that the message of this audience is that things are changing. They're changing very rapidly. And in talking about pharmacotherapy for obesity, I mean, this is one of the biggest changes that we are seeing in the management of cardiometabolic disease ever. This is bigger than treating hypertension, bigger than treating lipids. It's bigger than treating diabetes. It is, because so many more people have it. And I'm going to show you why I think that's the case and a little bit about where we're headed. But I want to say one thing, and that is that I am not speaking specifically about the medications, effects of the medications, and unfortunately I'm not talking about the specific recommendations in our standard of care. The reason is because it's not yet published. Like the other ones, the stigma and bias recommendations that Kim alluded to, and so I can't actually tell you what our recommendations are yet. You're going to have to wait until they get published. And here are my disclosures. And you're welcome to take photos. So, obesity is a primary goal of treatment for type 2 diabetes. This is a big change. I mean, I remember a number of the leaders of the American Diabetes Association telling me that why are you bothering with obesity? Just treat the glucose and everything will be fine. Am I the only person who heard this like 10, 15, 20 years ago, right? Just treat the glucose, it'll be fine. Doesn't matter what the weight is. Now we know that that is not the case. It's taken a long time. It's taken a lot of work by a lot of people. But we know that people with diabetes can be better if they lose weight and their glucose is under control. And an important point is that the magnitude of weight loss seems to play a very important role. So weight loss of 3 to 7% improves glycemia. Sustained loss of greater than 10% confers even greater benefits, including disease-modifying effects. And greater weight losses can improve long-term cardiovascular outcomes and even mortality. And it took us a while to understand this because we didn't have treatments that were effective enough. And because bariatric surgery, which is clearly effective enough to give these benefits, you can't do a randomized trial of bariatric surgery. Someone considers it to be unethical to randomize people to surgery or not. So the people whose lives are made focusing on randomized trials, like if it's not a randomized trial, they won't do it. Well, we couldn't do randomized trials of bariatric surgery. So we've known these things for a long time, but we haven't been able to get a groundswell of support for implementing these kinds of treatments because we did not have the data. But again, here are the key points that weight management delays progression from prediabetes to type 2 diabetes, perhaps the most important. It's highly beneficial for the treatment. It improves glycemia, reduces the need for other medications. It reduces cardiovascular risk factors and overall long-term cardiovascular risk, and it reduces other obesity-related health risks. And that's one of the real powers of treating obesity, is that it reduces a lot of risks at the same time. And here's a cartoon that I show all the time when I talk. Because just think about it, how do you get all of this benefit from treating one problem? If you treat diabetes, you'll get glycemia under control, but if you don't use a treatment that produces weight loss, you're going to have weight gain. You're going to make other things better. You're going to make other things worse, rather, but with weight loss, you make all these better. So you see that with just 5% weight loss, you get an improvement in blood pressure and glycemia. a little bit more weight loss, up to 10%. You get prevention of type 2 diabetes, improvement in MAFLD, dyslipidemia, polycystic ovarian syndrome, 10 to 15, improvements in cardiovascular disease outcomes, urinary outcomes, MASH, sleep apnea, GERD, and knee osteoarthritis. And then with 15% or more, we see remission of type 2 diabetes. We see an improvement in cardiovascular outcomes. We have the SELECT trial now showing that benefit with even less weight loss, right? About half the weight loss, and we've already got cardiovascular outcome benefits and improvements in HFpEF. So the evidence is building that treating obesity is a really good thing for health, but it still hasn't caught on. And this is a study that we did about 9 years ago, where we looked at the prevalence of treatment of obesity in the US population, and we compared it to the treatment of type 2 diabetes. And this is treatment of diabetes and obesity with pharmacotherapy up to 2016. And you can see that 86% of adults with type 2 diabetes were being treated with some form of pharmacotherapy. Very, very good. I'm not sure if that meets the standard of care. There are still some people not being treated. But for obesity, only 2%. 2% were being treated with pharmacotherapy. And I understand why, because our treatments weren't perfect. They were a little complicated to use. They had side effects, and we didn't have the supportive data to tell our colleagues in internal medicine, cardiology, and other fields that, gee, it's very, very clear that this needs to be done. And I looked at this again this year, and this is a survey from Fair Health, which is a not-for-profit in the New York area, which is dedicated to providing open source information for people about their health care, insurance, and benefits. And here is a conclusion of their very recent survey. Among all adult patients, the percentage who had overweight or obesity diagnosis and were prescribed a GLP-1 increased from 0.3% to 2%. So we finally got over 2% in 2024, a relative increase of over 500%. So the good news is over a 500% increase, but it's still the same number as 9 years ago. So I'm not sure if we actually have made much progress. I'm not sure we've made that much progress. So it's clear that obesity treatment of all types is being underutilized. Bariatric surgery, behavioral interventions, and medical treatment. And the key issues, you've heard about some of them already: stigma and bias, the lack of recognition of obesity as a chronic disease. And the evidence is clear. Like, there is no question that obesity is a disease, meaning that once you gain weight, it is very, very difficult to lose weight because something physical is going on. Something has changed your hypothalamic signaling. Something has changed the epigenetic expression in fat cells. And these factors make it hard to go back. It's kind of like, someone grows tall and they want to be shorter, right? You'd say that's ridiculous, right? But physical things occur in the process of weight gain that make it difficult, if not impossible. And obesity is not anybody's fault. People have susceptibility, they're taking medications, there are a variety of causes of obesity, and we now need to look at it that way as a serious disease and start treating it. There's limited insurance coverage for care and coverage for the cost of the medications. This is a major barrier. So when you look at people not using medication over time, that their use of anti-obesity or obesity medications declining over time, it's because they lost coverage. They can't afford it. These are major factors in our everyday practice of obesity treatment. There are few practitioners who are educated about treating obesity. A number of years ago, we started the American Board of Obesity Medicine. Kim is the medical director of the American Board of Obesity Foundation. So the goal of ABOM is to credential and make sure that people in the community are educated about obesity treatment. There's a lack of awareness that effective treatment's available, and all of this is exacerbated by the lack of an up-to-date standard of care for treatment. Standard of care. This is a very important few words because I've been on many guideline committees, and when you come out with a guideline for something like obesity, which is surrounded by stigma and bias, people look at it as a suggestion. It's like, oh yeah, okay, that's very nice. Yeah, treat obesity, okay, that's very nice. But standard of care means something very different. Physicians don't want to be caught practicing below the standard of care. Isn't that right? Anybody here is a physician or anybody who runs a medical organization knows that you do not want to practice below the standard of care. That is bad. So establishing a standard of care should help us to raise the visibility of obesity treatment. So I asked ChatGPT, the source of all knowledge, if establishing a standard of care would help with obesity treatment. And ChatGPT said, yes, establishing a standard of care for obesity treatment could significantly help both patients and healthcare providers. Here's why. It would improve the consistency in treatment. It would provide earlier intervention, reduce the stigma, improve insurance coverage, and provide clear guidelines for providers. So I know that sometimes ChatGPT can hallucinate. I've heard that. Someone put my resume into ChatGPT and said, here's a summary of what you did. And we found 10 papers that I had never written. So there are papers I wish I had written and I should have written, but I never wrote. But I don't think that that's what happened here. I think these are very, very accurate. So we're now coming out with the first standards of care for pharmacologic treatment of obesity. And I appreciate the work of the ADA and the committee members and the ADA staff in putting this together because it's very complicated, a lot of hard work, enormous amount of work over the past few months. So these are the topics we're going to be dealing with. The approach to the patient. How do you approach the patient? What are the goals of treatment? Which medicines do you select in a given scenario? Which lifestyle and dietary interventions should be recommended? And other clinical practice considerations. So the approach to the patient should be person-centered and non-judgmental. You've heard that already from Kim. Very, very important. That's the key. It's you and the patient against the disease. Remember that. You and the patient against the disease. You're not cross-examining someone for the crime of having the disease of obesity. And that is so important. You're on their side. You're going to help them, and it's centered around them. But you're not judging them for their illness. Shared decision-making, which is based on evidence, the best evidence available. And we have that evidence. In fact, I think I have it here on my phone, so if you want to, I have a number of the tables here. Thanks, Nuha. She sent me the tables. They're right here, but I can't show them to you. I'm really sorry about that. You need to balance the cost, access to the medications, the tolerability, and the adverse effects of medications. This is similar to type 2 diabetes and other metabolic diseases. So keep that in mind. This is no different than any of the other metabolic diseases. But the great news is if you treat the obesity first, you won't have to spend as much time treating the hypertension, the hyperlipidemia, the glucose, and the list goes on and on. So what are the goals of treatment? again, patient-centered, evidence-based, shared decision-making based on the severity of the disease, the complications, and life circumstances. And I can tell you that we've focused more on disease modification, the complications of obesity. So a complication of obesity is type 2 diabetes. I know that's hard for you to believe, but obesity can cause and worsen type 2 diabetes. I know many people in the audience think it's the other way around, that obesity is a complication of diabetes. That is not true. But the point is that by improving someone's glucose, that is a great goal, a great target for treating their obesity. We now have reduction in our weight goals that are achievable because of these new medicines. We were joking around before that we spend more of our time trying to stop people from losing weight because our new medicines are so effective. So we've got to talk patients off the ledge. They're like, whoa, I want to weigh what I weighed when I was 17 years old. I look great in that high school graduation picture. But when you're 72, it's not appropriate. You're going to have a lot less muscle mass. That is not an appropriate goal. And finally, what dosages should be approved for use? I don't know if any of you have encountered this, but we have patients who are on intermediate doses of the GLP-1s and GLP-1 GIP drug that are out there. And they'll be rejected by an insurance company because it's not a maintenance dose, right? It's not 1.7 or 2.4 milligrams of semaglutide, and it's not 10 or 15 milligrams, 5, 10, or 15 milligrams of tirzepatide. And one of our points is going to be that any dose can be a maintenance dose. Now that sounds totally obvious, right? But when we're dealing with insurers, we have a lot of difficulty. We need to say that specifically. The standard of care has to be that any dose can be a maintenance dose. Which medicine do we select? And for adults with complications, medicines with evidence of benefit treating the complication should be favored. And the best example is GLP-1 or a GIP GLP-1 for the treatment of type 2 diabetes. The evidence is unequivocal. In adults with obesity without complication, the use of medicine to prevent the development of the complications is also appropriate. So it's not that there's no underlying illness. It's not that they shouldn't be treated. And some people, I believe, have misinterpreted the results of the Lancet Commission or misunderstood the results of the Lancet Commission to suggest that somebody who does not have complications of obesity should not be treated. That is not the case. And then how do you manage patients who don't reach the goal with one medicine? Do you give up? Do you tell them you're not trying hard enough? No, you do something else. You do something in addition. Do you change the medicine? Do you add another medicine? So we had medicines rejected because the patient's on one medicine and the insurance company won't cover another. Do you refer to surgery? When do you refer to surgery? These are all questions we are trying to answer based on the data. What kind of nutrition should the patient have? And what dietary interventions should they use? And nutrition should be based on preferences and customized for the individual. Regular counseling will recommend to maintain appropriate intake of macronutrients to minimize potential nutritional issues. So things have changed dramatically in the past few years, from focusing on reducing calories to the quality of the diet, maintaining adequate protein intake, vegetable intake, high-quality food intake, rather than focusing on caloric intake. That is not as needed when we have medicine controlling these aspects. And finally, clinical practice considerations. What resources are necessary for delivering the care? And what if you don't have those resources? How do you manage the patient if you don't have those resources? What should be in the initial evaluation? This is critical because we're seeing the rise of telehealth with no evaluation. It's almost like these have become over-the-counter medications. So when we hear about the side effects or people developing problems, it's because no one evaluated them and they're getting no guidance. Has anyone seen that? I mean, it's really insane what is going on out there. And we need a standard of care to try to improve this. How do you provide the lifestyle and dietary management if you don't have it available? How do you arrange for collaboration? How frequently should you follow patients? And when should you adjust the dose? And how frequently should you be monitoring for adverse effects? And finally, this is the big one, managing prior authorizations. We have a pharmacy and pharmacists who do this and pharmacy liaisons. But this could be the bane of your existence, trying to manage prior authorizations. So all of these are dealt with to one extent or another. So here are the action steps for pharmacotherapy. Number one is look for the ADA standards of care for pharmacotherapy for obesity. They are coming soon to a journal near you. Learn more about obesity. If you do not know how to treat obesity, you should learn more about that. I'll tell you that the Obesity Society has a free handbook, a PDF of a handbook available on their website. You can go there, you can download the handbook, and it is free. I'm one of the authors of the handbook, by the way, but it's free. In your practices, diagnose obesity. We see many people where there are 5 different comorbid conditions diagnosed, but the obesity is not diagnosed. Why? Because the doctor is afraid that if they put obesity in there, the claim will get rejected. So you may not want to make it the first diagnosis, but if you make it the second or third, you could usually get by. And finally, treat obesity before you have to treat its complications. Thank you very much for your attention.
Thank you so much, Lou, that's your water. And thank you, Kim. And I wanted to thank the ADA scientific team who's behind the scenes. And people think they're so big and scary, but I mean, they're right there. But they're brilliant, that I will tell you. So now I think we can take a few questions. Is that okay? All right. So question right there.
John Parnell from Oregon. I have a question for Dr. Roney. So you treat a patient with obesity. You have it on their problem list. Can you hear it okay? Can you hear? Okay. Now their BMI is 25 or 26. Do they still have obesity?
In my opinion, they do.
Should they
So
take
if
that
someone's
off?
glucose is normal and they're on 100 units of insulin, did you cure their diabetes? And the answer is no, they still have diabetes.
So-
They still have the obesity. So in our practice at Weill Cornell, we code the original BMI. That is the diagnosis.
And do you keep it at the original BMI category that they were at, or do you downgrade it?
We keep it at the original BMI. And again, our charts are reviewed again and again, and that is our practice.
So we're going to alternate. We'll do this side and then we'll do this side. Please go ahead. Go ahead.
Hi, Pamin Dakaban from Cleveland Clinic. I have a couple of questions. So the first one is, we always talk about weight and obesity and everything. Is there plans, I know you probably can't talk that much about it, about getting rid of BMI and replacing it either with body composition or waist to hip? At the Cleveland Clinic, we are currently getting ready. We are setting up a global obesity center. So we are trying to see how we can kind of generalize care across different countries. And BMI, obviously, as we know, is problematic, especially when we look at different populations.
So I guess I can say that we will have a chapter focusing on diagnosis and evaluation and screening, as I mentioned, and we are taking on that question. We're working on that right now, so I can't tell you what it will be, but that will be covered because it is a critically important issue. And so the team is very focused on really trying to come up with a looking at the evidence in its entirety, as well as thinking about use in different context areas to make sure that it's feasible and implementable as well.
Gotcha.
Do
And
you
just
go
as
to this side? No, sorry. Did you have a follow-up?
I did have one more, which is because Dr. Liu just talked about, telemedicine companies and talked about the ABOM for physicians. Is there going to be, or is there a recommendation for a pathway for mid-levels also to have some sort of certification when they practice obesity medicine so that we have people better trained for obesity medicine, especially for telemed companies?
So there currently are some certificate or assessment-based certificate programs that are available for nurse practitioners, PAs, dietitians that are available. To date, there isn't a board certification that is equivalent to American Board of Obesity Medicine certification for physicians. So further plans on that is sort of a longer conversation. But right now, there are some certificates and assessment-based certificates available.
Thank you. Thank you for your patience. Go ahead.
Thank you. We have treatment target values for LDL cholesterol, HbA1cs, and hypertension. What is the treatment target values for obesity management? How do you share goals to your patients when they are in front of you? This is your goal for you in obesity treatment?
Right. As far as treat to target, great point. One thing I want to mention about the standards of care is that this is a living document, meaning that this is going to be renewed every year. And as evidence builds, we are going to be changing this document on an annual basis. So that right now, our targets are still based on percent weight loss, perhaps, or older BMI categories. But as time goes on and evidence builds, I think we will ultimately treat to specific BMI targets, waist to height ratios, and other ways of measuring obesity.
So what should be your BMI target? 10%, 5%, 15%? What would you suggest to your patients? This is your goal for your treatment.
Sure. I would say the first goal is to treat the underlying complications of obesity. That would be the first thing to target. In people who don't have complications, it depends on how effective the medicine is, what medicine is covered, how much it costs. There are a number of different ways to evaluate that.
In our country, India, nothing is covered by the insurance. The patient has to pay from their pocket.
Ask that.
But hopefully they're not as expensive as out-of-pocket here in the U.S., hopefully. All right, we'll take a question from here.
Yes. Hi, my name is Yael Maurer. I'm a metabolic disease specialist from Cleveland Clinic. And I don't have a question, I have more of a comment. I am really excited about all this movement and attention on obesity and how it impacts diabetes. The only one thing I think we do need to move away from thinking of obesity management as a stepwise approach. And we need to think about the patient we have in front of us. While lifestyle changes first and then medication and then surgery may be appropriate for some patients, a patient that comes to us with a BMI of 52, for that patient, recommending medications or surgery from the get-go may be appropriate, just like we would recommend medications perhaps for someone with an A1C of 10 when they come to see us. Thank you.
I'll just say that the pyramid that I showed was not meant to indicate a stepwise approach. And in subsequent chapters, that will be one of the things of instead of thinking you must do 6 months of lifestyle before I can offer you anything else. Well, that doesn't really make sense if you have a greater disease severity. And so it's really thinking about individualizing and caring for that person in front of you and tailoring based on both their preferences as well as their clinical disease presentation. And so I'll just say that concern will be addressed.
Thank you.
Thank you. We're going to go to this side since.
Thank you. Keith McGee. Question here related to PBMs that initiated their prior authorization criteria at a BMI of 30 that have now taken it to 32 and patients being denied because they were say 31 BMI at onset. And just curious, any success stories of navigating the prior authorization?
I have no specific miracle cures for PBM rejection of prior authorizations. We focus on looking for complications of obesity. And it's surprising how many people have them. The majority of people with obesity, you will find have something. And, if they have had an MI, if they have coronary disease that's proven, if they have sleep apnea, the list goes on and on. So that is how we've gotten a number of our patients coverage. But it's very, very difficult. I agree.
Thank you. And I'm going to go here.
Hi, Lou, Kim, Amy Rothberg from the University of Michigan. Lou, I'm going to push back a little bit on what John Purnell just asked you, because how do you reconcile the patient's goals who fall in a normal weight BMI classification, who were previously living with obesity, removing that from the problem list, because that's the patient goal, with, billing the insurance. And I'll tell you, from my own experience, the payer rejects that history of obesity or a BMI of 35 that they had previously.
Well, that'll be in our standard of care. We're going to put that in the standard of care, and then if they do that, they're below the standard of care. I mean, I'm being facetious, but those are the kinds of things that we are looking at and we have to do.
Thank you. Thank you for your patience.
Thank you very much for giving me the opportunity. As a cardiologist, I'm interested that whether this obesity is related really with the hyperlipidemias, and number two, whether hyperlipidemia is this obesity has contribution in this endothelial dysfunctions like the other cardiac risk factors for the atherosclerosis. Whether obesity is related with the hyperlipidemia, if the patient is obese, is it necessary that at the same time he has got hyperlipidemia? And number two, whether obesity is directly related with the endothelial dysfunction and causing the atherosclerosis?
Relationship between obesity and hyperlipidemia.
So the primary relationship between obesity and hyperlipidemia is hypertriglyceridemia, although LDL can also be improved. And particularly with the GLP-1s, we see significant LDL, but really substantial triglyceride improvement. Over time and with the magnitudes of weight loss we're seeing, many of our patients have been able to reduce but not eliminate the statins and other medications they've been on.
Okay, thank you.
Come up and we'll...
Thank you so much. So I would like to thank everyone for their attention and their participation. We're above time, and I think there's another session coming in.
Okay.
So thank you so
Thank you.
much. Thank you.